All right, yeah, thank you. I'm relatively new at this. I've been practicing in Calgary for a little over 3 years now. And so it's nice to get the opportunity to attend one of these meetings and meet folks like you. And it was training with Judy in Ottawa that kind of had me catch the bug for this kind of stuff. So nothing to disclose. What we'll get to, I'm already lying to you. I'm not gonna go over the clinical clues because already that's what Dr. Horn just did, but it is what we do in genetics. We'll briefly touch on why accuracy in a family history is important. Go over kind of what the current genetic testing landscape looks like, and from a clinical basis, I'll try to stay out of research. Give a framework of who we test, who we don't test. And I'll try to really go into the nitty-gritty of variant interpretation. I'm glad there was a question before, especially with a captive audience of mostly non-geneticists. It's probably a good time to force it on you. And then kind of get a sense of what the future might look like in the clinic as well. The disclaimer is that, it's going to vary province to province regionally depending on your health authority. So what we do in Alberta is likely different somewhat from what happens in other provinces, but I think the general principles will apply. Again, we use history and exam to guide testing. I'm not going to get into that. With the family history, there's no great secrets. You just need to put the work in. You want at least 3 generations. More is better, especially with aortic families where you're often dealing more with adults than maybe kids. You're looking for those red flags of connective tissue disorders, aortopathy, sudden deaths, that kind of stuff. But the big thing is putting the work in to get records, review records. Patients mean well, but they are usually wrong. Most of us don't know the specifics of our family members' medical histories. So I just threw this case up as an example. It didn't come through too long ago, but I'm sure we've all seen some version of this where it was a 65-year-old gentleman who dissected, and he had all the traditional risk factors. But there was a history of aneurysm apparently in his father, who died suddenly in his mid-50s, and a brother with the same thing. So certainly worrisome, and we saw him. But when we actually went to the trouble of getting the records, his father had an autopsy, reviewed it. He had classic atherosclerotic heart disease. He had an MI. There was no evidence of aortic involvement. All of a sudden the story changes a little bit. Similarly, his brother had the same risk factors, if not more, was quite unhealthy, nothing in his medical history to suggest anything else. So again, the family history immediately changes once you get a chance to actually dig into the records. And so in the end, this guy did not get at least one of our traditional panels for testing. But you really need to, it takes time, but you need to put the work into it. In terms of why testing, most of this is fairly obvious to this group too. There's value in having a definitive diagnosis. It's hard to treat something when you don't know what exactly you're treating. The refinements in management, be it cardiac or non-cardiac surveillance, deciding when to operate, how to treat. But for us, it's really getting into the cascade counseling and testing too. And you can only start testing, genetically, you can only start testing family members when you have a real mutation to look for. Without that, you rely on surveillance, which I don't have any clear answers for what that looks like, who, how often, what modality. Again, this is going to vary. So certainly if you can target your screening to those who truly need it, who are gene positive, that's going to help the clinic and the family. So testing, what does it look like? I think as a geneticist, it's in my contract somewhere that I have to show some version of this slide in every talk that I give. The point is that Moore's law, so Moore was a computational scientist in the 60s who predicted that every 2 years the number of processors or something like that, basically computer power would double every 2 years. And with that, with power, prices would drop. And so much of genetics now is driven by bioinformatics. You need good computers. And so, it followed along for a while. Which one's my pointer? Here, and then this blip at around 2007 is when next-gen sequencing came around, and then it just quickly outpaced everything. So the point is that things are cheap now and easier to do, and there are no longer the barriers that we might have had clinically to get testing done. Your standard panel is well under $1,000 now, and exomes are soon to follow. Quickly, the old way of testing, and this wasn't that long ago, would be sequential. So you'd see your patient, you'd come up with your differential, you'd pick your gene, and you'd test. And if you were right, great, good for you. If not, you'd move on to the next one. And it took time, and it could go on indefinitely. Nowadays, you can do it all in parallel. And you can do as many genes as you want from panels to exomes. And this is why it's called massively parallel sequencing. You're doing everything at the same time, also known as next generation sequencing. So this really kind of revolutionized things. I like this figure here. Basically, it gives you a sense of kind of how testing is guided. You go by phenotype and genetic heterogeneity, meaning, do you have few genes that are responsible or many? Up in this corner here, you have a very specific phenotype. Think Marfan syndrome with ectopia lentis, where there's really one gene that's going to cause that. Cystic fibrosis, there are other conditions in there. And then when you get down to this corner here, where you have very non-specific, intellectual disability, cerebellar ataxia, there's an infinite number of genes that are responsible there, so you're going to take a broader shotgun approach, usually, by way of a very large panel, or nowadays, exomes. We live kind of in this world here, at least today, this multi-gene panel, aortopathies, cardiomyopathies, arrhythmias fit nicely into there in terms of gene number and phenotype. Again, in terms of genes we're looking at, this has been covered, but most of them live somewhere, either, in the extracellular matrix up here, have to do with the TGF-beta pathway or the smooth muscle contractile apparatus. And so with that, panels tend to reflect genes in there. Now again, where you are, this is going to vary. So I know in some centers, testing is done in-house through your own genetics clinic, where people have had the opportunity to customize and design their own panel. And then in Alberta, we're not there yet. We're looking to repatriate, but you're reliant on commercial labs, and there's a lot of them out there. They're all pretty much the same at this point in terms of cost, turnaround time, answering emails, that kind of stuff. But they do vary in gene content. So I did a quick glance at some of the bigger labs out there, and you'll see anywhere from 26 to 41 genes. Well, I'll get to it in the next slide, but that's not necessarily what you want. They're businesses, and I guess the model is more is better, but that's not always the case when it comes to testing and then dealing with what comes out. So thankfully, earlier this year, this was published by a group of experts, some of whom are in this room, kind of looking at the clinical validity of these genes that tend to show up on these panels or have been associated with aneurysm and dissection. There's 53 in total, and they were able to break them down into 5 groups. So your category A, there's 11 of them there. These are your definitive, no one's going to argue that there's an increased risk of aneurysm and dissection. Your category B, where there are often more non-cardiac features that predominate. There does appear to be an increased risk of aneurysm, but there's no great evidence that they're going to progress to dissection. So probably should be treated differently than the A's. Category C, there's a few of these. You can see aortic enlargement, but the bottom 3 are primarily renal, your polycystic kidney disease and Alport, and then CVS for homocystinuria. So there's other things that you're looking for. Category D, again, these show up on many panels: osteogenesis imperfecta, classic EDS, HHT, a lot of things where you really probably shouldn't be looking at them if you have a patient with aortopathy. And then this group of genes here were just considered too new. They were only discovered recently. We just don't have the evidence to really kind of comment on whether they should be upgraded to A or B or C. But the point is kind of be careful what you test. And nowadays, thankfully, at least commercially, labs are pretty receptive to modifying these panels, meaning a lot of them are on an exome backbone where they're sequencing every gene, but you can then say, listen, I'm only interested in knowing what's going on in maybe these 11 genes plus these 8, and you're blinded to what's not there so that you don't have to deal with the inevitable variant. Good time to mention that really in practice, you only ever test an affected individual. There's very little value, there are very, very rare instances where you might test an unaffected individual, but in reality, you're only going to test the person who's likely to give you an answer. When you talk about testing unaffected individuals, that's really at-risk family members where you have a real deal disease-causing mutation to look for. So that's your difference between diagnostic testing versus predictive, especially with a healthy individual. Testing, it's primarily blood. We're using more saliva nowadays. It's cut down on turnaround time. Despite what the internet might tell you, patients are not this happy to spit into a tube in front of you while you talk to them. The process is pretty streamlined now. Well, you decide if you've got a case of isolated thoracic aortic aneurysm dissection or syndromic. You're going to order a panel. They're probably going to be fairly similar, especially if you kind of try to customize them. Not much difference nowadays. Cases where you might be a little more reckless and go after a single gene. Again, if you have ectopia lentis, it's probably Marfan. You can save the money on looking at everything else. If they have classic vascular EDS, again, I've had some success in at least targeting this gene. But then with the isolateds, like this is where, again, I'm sure everybody has their own way of practicing, but when they're not a slam dunk familial case and there's a lot of risk factors, it can be hard to know what to do. So I've thrown in a couple of these, again, just to maybe have people think about it. But you've got your guy in his late 50s with moderate enlargement of the ascending aorta. He's poorly controlled hypertensive. He's got all the usual risk factors and no family history. Now and then they make it to the clinic, but I'm not going to test this guy. Older woman, big root, family history, but primarily of abdominal aortic aneurysms, which less likely to be monogenic. Hard to say, see what her exam looks like. And then these cases where you have your arteriopathies, your medium-sized vessels, your spontaneous coronary artery dissection, and the enigmatic fibromuscular dysplasia, it can be challenging to know what to do with these patients as well. Again, and the curse of the tall, skinny kid who gets sent to your clinic, who's got that borderline score, and they all kind of reach 6 or 7 the same way. I've tested them less and less. But the point is that there's no clear answer, consensus. I think it's, everybody uses their own clinical judgment to decide what to do. But be warned that, I'll get into the test sensitivity, but it's very easy to make your sensitivity look bad. If you test everyone who walks through the door, it's a little harder to make it look good. But in terms of mutation detection rate, so like we talked about, if you have a patient with non-syndromic TAD, about 1 in 5 will have a family history. Usually that means a first-degree relative. If you test them, about a quarter, the numbers vary, 20, 30%, will have a mutation in known gene. So that's about 5% of all comers. Relatively low yield, higher yield if you're talking about the ones with a family history. And so when you see patients and you set up testing, you need to manage those expectations. Like a lot of them will walk in thinking, we're going to order a test, we're going to figure this out, and everybody's problems will be solved. And the reality is we fail more often than we succeed. And they need to know that before they sign up. By comparison, other panels, hypertrophic cardiomyopathy, you're going to find a mutation upwards of 50%. Long QT, it's a little better. And then, obviously, if you're doing targeted testing where someone meets Gantt criteria for Marfan, they have features of vascular EDS, that should be well north of 90% in terms of finding a real mutation. But the point is, you don't see 100% up here anywhere. So really, you can never use genetic testing to exclude a diagnosis. Like we all have that Marfan patient who walked out of a textbook with a systemic score of 15 where we can't find a mutation. That doesn't change the diagnosis. But again, you need to counsel that the absence of a mutation doesn't mean that it's impossible. All right, variant interpretation. I had so many slides to get into this, and I really had to trim it down for 20 minutes. The point is that when it's important to tell patients, like when we sequence you, especially the more genes we sequence, we are going to find a lot of variants. We're going to find a lot of stuff. Pretty much all of it doesn't matter. It has no impact on your health. It's something you inherited from one of your parents. So most of that genetic variation is normal. If it was all the same, we would be clones of each other. In terms of classification, this is where you see these terms benign, likely benign, VUS, likely pathogenic. When it gets down to reports, you're never going to see these ones. A lab should never tell you about these because they're mostly irrelevant. It's the further 3 that matter. And again, you need to discuss this with patients before you do the testing. They need to understand that, again, chances are still that we're not going to find an answer, or there's still going to be some ambiguity. There's going to be one of these variants of uncertain significance where we're not necessarily prepared to act on it. This is in 2015, the American College of Medical Genetics and Genomics put together these guidelines in terms of how you classify these variants. We don't need to get into, again, all the specifics, but there are different things that we'll get through here, and they're all weighted in terms of strength to make a case for pathogenicity or it being disease-causing versus benign. So, the top one here, population data. When you take the variant and say, is this common, is it rare, or better yet, for your interpretation, has it been seen before in affected patients, in which case that carries a lot of weight. Computational and predictive data. So again, there's computer modeling systems that use with the amino acids. Is it evolutionary conserved? Is it the size, the charge, the polarity, where it is in the protein? It carries a lot of these things. Yeah. Functional data. If you're lucky, there has been research done on this variant, and you have a sense of what effect it might have. Segregation data. So how does this variant segregate in the family? Do all the affected individuals in the family carry the variant, and none of them don't? And certainly the more distantly related relatives who are affected and have the same variant can carry some weight too. Is it de novo? So obviously anytime there is a new genetic change in a patient that neither parent has, that makes you more suspicious at least that it could potentially be damaging. Allelic data, this is more applicable to recessive disorders. We're dealing primarily with dominant, a few X-linked, so we'll kind of skip that. Other databases. So again, there's a lot of reputable sources out there. There are disease-specific databases. You need to access those as well, and certainly with this group, there's the UMD database that I access a lot. And then other data as well, and this is where you can kind of take your Bayesian approach and again, if you find a variant in a gene that really fits the phenotype, where already your pretest probability was high for that, that should carry some weight too. And then recently, so this is a general classification guideline. Recently, there's been a group who have kind of tried to modify this for FBN1 for Marfan, because again, we know that there are certain parts of the gene where mutations tend to carry more weight. So this can be modified. I also want to touch on the importance of population databases. So there are some really cool tools out there that people should be aware of. So GNOMAD, so the Genome Aggregation Database, this is out of the Broad Institute in Boston. And this is a database of what's called normal human genetic variation. And these are healthy adults who, I think the phrasing they use is, or free of severe pediatric illness. So adults who claim to be healthy. You've got about 125,000 plus whole exomes and a little over 15,500 genomes, and this kind of serves as a reference normal database. So what I've thrown up here is FBN1. So again, you can see your protein here, you've got your depth of coverage, these cool little constraint metrics where they predict how tolerant the gene is of either missense changes or severe loss of function ones. And then they've recently updated it where you can highlight all the known pathogenic and likely pathogenic variants. So you can see it kind of covers the whole thing. You can dig in deeper and actually go look by variant. And so to orient yourself here, we're zoomed in somewhere in the middle part of the gene here. And I've highlighted a few things, like you can play around and look in here. So first one here, you've got this GLU 1584 lysine variant. When you slide over, you see that the allele count is 39. So it means that there's 39 adults walking around with this variant. Unlikely to be damaging. That's too common for healthy adults. There aren't 39 people with Marfan syndrome walking around who don't realize they have it with the exact same genetic variant. That's too common. Interestingly, there's two cysteine changes. I didn't actually go to the trouble of checking to see if this is in a calcium binding domain, but they each have an allele count of 1. This, they could be affected, I don't know. We don't know much on the phenotype of these individuals. And then this one here you can zoom in on. So this is kind of that allele count of 8, that mid-range, kind of rare, kind of not, but then you can dig in further and see that all 8 of those are people of East Asian ancestry. And what part of East Asia we don't know, but what that tells us is that this variant, while maybe rare in this large database, may not be so rare in certain parts of the world, and that applies to many variants too. There are many population groups that are underrepresented in these databases, so you always need to keep your patient's background in mind when you dig into these things too. So important points, and I think I put the ribbon there to remind myself that this is important. So when you deal with these variants, it's one thing to get a VUS and then decide whether or not this explains your patient. And especially if they've already had their dissection, they're going to be followed in cardiology. If you're right or wrong, they're likely still going to be followed the same way. But it's how does this apply to the rest of the family? So, questions you can ask yourself is with this variant, would I test a pregnancy for it? Meaning, if the couple is going to decide to terminate a pregnancy based on the result of this genetic test, you need to be damn sure that what you're telling them is right, that it is truly the disease-causing variant. Would I test a healthy relative? So the kid who's got dreams of playing in the NHL, who's fine, if you test him and he has it and you're sentencing him to a lifelong screening, medications, stopping hockey, all that kind of stuff, again, you need to be right. Almost as scary, like would I clear a family member? So if you test someone and they don't have it, and you say, all right, you're good, don't worry about it, and they dissect a few years later because you were wrong about the variant, that is a terrible outcome. And then also too, it's that label, and young kids, there's an impact on insurability and their future life and getting a mortgage, and all these things need to be considered before you act on that variant. So what it means is that we sit on the fence for a while, unfortunately. You can't really lead, like you can have your intuition, but it can be hard to act on it. I find the Gartner hype cycle, so this is how people adapt to new technologies, applies well to next gen. So you have your innovation of next gen, and then with time you get quick panels and exomes and genomes. Everything's great, and we say, sequence everyone, we've got this figured out. And then soon enough you realize that the sequencing part is easy, but the analysis is more difficult, and maybe we got ahead of ourselves. But then with time you get refined testing, pick the right people to test, look at the right genes, work on the bioinformatics, collaborate, share data, research, and so in reality, we are somewhere up here, and the low probably wasn't this low, but I think it captures it nicely towards probability or productivity. And then quickly, what's next? One of the big things is reanalysis. So nowadays, your sequencing data is on a hard drive somewhere. It's not a gel that was run that gets thrown in the garbage after a while. So the data is there and it needs to be reanalyzed on a regular basis. And how that works, I think we're still trying to figure out, but either you're looking to reanalyze for the variants you found. Have we learned anything new about these variants? Is it now considered to be benign? Is it damaging? And then when you get into the world of exome sequencing, you need to look, and maybe a new gene was discovered in the last year that we just didn't know about last year. So a system needs to be in place to look at the data that's already there. You don't need to keep bringing the patient back in to get another blood draw or have them spit for you. And then the question is what's going on in the rest of the genome, right? So there's about 20,000 genes in total. About 4,000 or so have been linked, give or take, have been linked to human illness. And the aortopathy genes, I threw 25 up there as a random number, but makes up just a sliver of that. So the question is what's happening elsewhere? And the next steps, obviously, there's exome sequencing and there's genome sequencing. Exome sequencing is probably, most of its utility is probably, like it's picked out the low-hanging fruit. It may, it will pick out maybe a few new genes kind of with really informative families, but I think whole genome sequencing is where things are going to go in the future in how we use it in our clinical practice. So again, like for your 5 to 10% of Marfan, Loeys-Dietz, vascular EDS patients where we can't find a mutation, you need to wonder about, sorry, I'm jumping around here, regulatory regions, enhancers, modifiers, things around the gene that we're not looking at with current next gen. But then the reality is that with exome sequencing, like there's a chunk of 70% or so that are unanswered here. We're not going to answer all of that with novel gene discovery. It's going to be, this concept, what I'd like to introduce you of the polygenic risk score, and Dr. Milowitz touched on this already. But the idea, it's kind of that GWAS idea where you need massive numbers. You need lots and lots of people. You get your healthy controls, you get your people with the disorder, you sequence them all and you basically see where they differ. And then you generate, the Manhattan plot, or we'll call it the Toronto plot, where you get these little peaks and you look to see kind of what right combination of variants do certain people have that places them at a higher risk. And so this is not new to cardiology. It's around now for coronary artery disease and a lot of other things where you can come up with odds ratios where basically, depending on someone's score, which is generated based on that combination of variants, what kind of risk are they at? And again, this is what is likely to explain those people who don't have that clear monogenic dominant inheritance, but that cause them to dissect at a younger age. I think a lot of the answer is going to lie in here. So otherwise, and this is polygenics in action. I try to shoehorn a baseball reference into every talk I give. They're in Expos uniforms, but this is the next up-and-coming Blue Jay that you guys are going to get to see play here. The son, Vladdy Jr., the son of a Hall of Famer, Vladimir Guerrero. So yeah, I wish I was in Toronto to watch him play, because he's going to be incredible. That's it. Thank you.
Thank you very much, Julien. Any questions for Julien while Dr. Milovic and Horn come up to join us? Dr. Bradley has a question for you.
Hi, Julian. Just a little bit more in the ways of a comment, I suppose. A very lovely sort of talk. I suppose one of the points is you said questions to ask yourself, and it's really the questions that I asked the geneticist myself. So, but it sort of feels sometimes, like now the difference between being in Toronto and Saskatoon, that our genetic testing is very resource dependent, and it feels like in the 10, 12 years that I've been doing this, that the pendulum has sort of swung from no genetic testing, because we just had Marfan's, right through to the other spectrum where we test everybody and we create all these problems because we get all these variants of unknown sort of significance. And it's sort of like, well, we've got 2 drugs and we've got surgical indications that are based on diseases and sort of genes now, and it's lovely to see Diane bringing some statistics to it with Kaplan-Meiers, and that it may be, as in your lovely slides, saying in the future, that we've gone into the trough of disillusionment and that maybe we're going to come back out again. But it's really difficult today to sort of, when I now work in a resource deficient, I suppose, space, to sort of make that decision about genetic testing when it's really difficult. Does it actually influence how the way I manage patients? We'd like to put everybody into little pigeonholes, but they're really not getting there. So I suppose it's just really a comment, not really a question.
Yeah, no, I agree. It can be difficult because, part of the trouble is if you don't sequence everyone, you don't know what's going on. But I think that type of question is best answered in outside the clinic. Clinically, it's being a good steward and testing the people where you think you're likely to get an answer, and trying to enroll the ones who don't quite fit into other larger studies where we might help to find an answer. But it is a constant struggle.